Good afternoon. Today we'll be discussing long-term maternal health after hypertensive disorders of pregnancy. I am Kashifa Jafta, and for this talk I was supervised by Professor Hall. The outline for today's presentation will include a discussion on the various complications that may arise later in life from hypertensive disorders of pregnancy. Hypertensive disorders of pregnancy complicate 5 to 10% of pregnancies globally. 2 to 5% preeclampsia, 3% gestational hypertension, and 0.5 to 2% chronic hypertension. According to the World Health Organization in 2018, 1 in 5 women suffer from hypertension, and almost half of mortality in women is caused by cardiovascular disease. Preeclampsia complicates 2 to 5% of first pregnancies and recur in 15% of subsequent pregnancies. This recurrence results in a robust increase in the risk for cardiovascular disease. As per the 2017 revised Saving Mothers Annual Report, potentially preventable deaths caused by hypertensive disorders of pregnancy have steadily increased in the last few years and is now the second most common cause of death, majority of which occurring in the postpartum period. Hypertensive disorders of pregnancy is associated with an increased lifetime cardiovascular disease risk, and women should be advised to actively test for modifiable risk factors. Preemptive screening, early recognition, and treatment may result in prevention of long-term morbidity and mortality. The classification of hypertensive disorders of pregnancy. The two tables illustrated, the first being from the ISSHP document for hypertensive disorders of pregnancy, ISSHP classification, diagnosis and management recommendations for international practice. And the second being from the American College of Obstetrics and Gynecology. According to the ISSHP, or the International Society for the Study of Hypertension in Pregnancy, the recommended guideline is the table seen right on top. It divides hypertension known before pregnancy or present in the first 20 weeks and hypertension arising de novo at or after 20 weeks. Masked hypertension in this classification is known as hypertension where the blood pressure is normal upon a clinic visit. However, it is diagnosed after 24-hour ambulatory blood pressure monitoring and is sought after in a patient noted to have target organ damage of chronic hypertension. Transient gestational hypertension is hypertension or a blood pressure documented to be more than or equal to 140/90 at a clinic visit. However, it is only one raised blood pressure. All the subsequent blood pressures are noted to be normal. Preeclampsia can arise in isolation or superimposed on chronic hypertension. When one looks at the American College, the ACOG guideline, it is noted that preeclampsia is de novo blood pressure elevations after 20 weeks of gestation coupled with proteinuria or other end organ dysfunction. According to the ISSHP guideline, proteinuria is not required for the diagnosis of preeclampsia. The pathophysiology. Mechanisms linking hypertensive disorders of pregnancy and cardiovascular disease later in life are still being unraveled. Preeclampsia involves global systemic dysfunction with an unknown precise cause. Mechanism of dysfunction includes widespread endothelial dysfunction, impaired angiogenesis, decreased vascular compliance, structural and functional cardiac impairment, and elevated biomarkers of cardiac remodeling. Proposed hypotheses that result in the complication of cardiovascular disease are hypertensive disorders of pregnancy and cardiovascular disease share common predisposing risk factors like chronic hypertension, diabetes mellitus, hyperlipidemia, and increased body mass index. Vascular insufficiency detected in the placenta of preeclamptic women display lesions characterized by inflammation and lipid-laden macrophages, a feature characteristic of early atherosclerotic plaques. Cardiovascular disease is caused by endothelial dysfunction that persists after delivery. Markers present up to 8 years postpartum include endothelial dysfunction, arterial stiffening, and systemic inflammation. Activating angiotensin II type 1 antibodies persist up to 18 months postpartum and bind to angiotensin 1 receptors, thereby inducing endothelial damage. These hypotheses display a cause versus effect relationship. Preeclampsia causes structural and functional changes or damage to the previously healthy circulatory system versus pregnancy that acts as a stress test, thereby unmasking a predisposition to underlying cardiovascular disease. The first of the long-term outcomes is peripartum cardiomyopathy, which is one of the most proximal complications occurring as early within 6 months postpartum, or peripartum. Peripartum cardiomyopathy is defined as new onset cardiac failure with reduced left ventricular ejection fraction in the peripartum period without an identifiable cause. Women with preeclampsia are 10 to 20 times more at risk of peripartum cardiomyopathy. Mulhame et al. Showed that women diagnosed with preeclampsia in the presence of certain conditions are at an increased risk. This risk is 1 in 5, and they are at risk of superimposed peripartum cardiomyopathy. These certain conditions, namely in descending order of risk, is chronic kidney disease, multiple pregnancy, chronic hypertension, and advanced maternal age and type 2 diabetes mellitus. Preeclampsia with superimposed peripartum cardiomyopathy cases are also 1.2 times more likely to experience a major adverse cardiac event within the first 6 months following the condition. A major adverse cardiac event is defined as acute respiratory distress, pulmonary edema, acute heart failure, diastolic heart failure, cardiac arrest, and any condition requiring ventilation, cardioversion, transplant, or external pacing. It also includes thromboembolic events like pulmonary embolism. The most common major adverse cardiac event found in preeclamptic patients is acute diastolic cardiac failure and pulmonary embolism. Prompt identification of patients at risk and management could result in decreased morbidity and mortality. Chronic hypertension is defined as a systolic blood pressure equal to or more than 140 millimeters mercury and a diastolic blood pressure more than or equal to 90 millimeters mercury. It is prevalent in 30% of the adult population in Europe and the United States. Chronic hypertension is an established risk factor for chronic kidney disease, cardiovascular disease, and cerebrovascular events. The American Heart Association has shown that the risk for future hypertension is increased 2.3 to 6.7-fold in women with a prior history of preeclampsia within 15 years postpartum. Studies have elucidated that this risk is further increased 2 to 3-fold in women who have experienced recurrent episodes of preeclampsia. Recurrent episodes of preeclampsia is defined as preeclampsia present in 2 or more pregnancies. The pouch study by Dunietz et al. Showed an association between moderately elevated blood pressure in pregnancy, which is a systolic blood pressure more than or equal to 120 millimeters mercury, and a diastolic blood pressure more than or equal to 80 millimeters mercury. It has shown an association between this blood pressure and the development of hypertension within a 7 to 15 year period. This study showed an association between moderately raised blood pressure arising before 20 weeks and after 20 weeks. In the group in which this moderately raised blood pressure was present before 20 weeks, there was a greater association with hypertension later in life. However, the association existed in both groups. Gestational hypertension develops after 20 weeks gestation and resolves by 12 weeks postpartum. If this resolution does not occur, it results in chronic hypertension. Although gestational hypertension is not a multisystemic disorder like preeclampsia, newer evidence suggests an association with cardiovascular disease in later life. A well-established and known association exists between hypertensive diseases of pregnancy and cardiovascular disease. A prior history of hypertensive disorders of pregnancy results in a 2 to 5-fold increased risk of developing cardiovascular disease. The risk for cardiovascular disease is 2 times higher in the preeclamptic group. In multiple meta-analyses done, 4.2-fold increased risk of cardiac failure, 2.5-fold increased risk of coronary artery disease, and 1.8-fold increased risk of stroke or cerebrovascular event. The risk for ischemic heart disease, atherosclerosis, cardiac failure, and cerebrovascular event increases 2 to 3-fold after recurrent preeclamptic episodes. As previously stated, recurrent episodes being present in 2 or more pregnancies. There is now evidence to suggest that recurrent gestational hypertension has a similar cardiovascular disease risk to preeclampsia, though the pathogenesis is largely unknown for gestational hypertension. Relative risk of cardiovascular disease increases with the severity of preeclampsia. Coronary artery calcification. A history of preeclampsia is a sex-specific independent risk factor for major adverse cardiac event. Coronary artery calcification is measured in Agatston units by computerized tomography and is an important biomarker of cardiovascular disease. The extent of CAC correlates with the risk of cardiovascular disease in even asymptomatic individuals. A prospective cohort study by White et al. Showed an association between preeclampsia and higher CAC scores 30 years later. A positive CAC in women with prior history of preeclampsia or with traditional risk factors for cardiovascular disease can be useful in primary prevention, lifestyle, and disease modification. Cognitive impairment. Preeclampsia has been associated with subjective cognitive symptoms approximately 5 years postpartum. Self-reported deficits in memory, perception, motor functioning, and attention years to months after pregnancy. However, no clear evidence of impairment on standard neurocognitive tests have been found. Preeclampsia has been associated with an increased frequency and severity of white matter lesions seen on neuroimaging studies. White matter lesions have been shown in elderly patients on MRI and has been associated with an increased risk for dementia, cognitive decline, or cerebrovascular events. The clinical implication of these lesions in young patients remains unknown. No reported increased risk of dementia, i.e. Alzheimer's or vascular dementia, after history of preeclampsia has been shown in the evidence. Mortality. Hypertensive disorders of pregnancy is associated with an increased lifetime risk of cardiovascular disease within 10 years of the associated pregnancy. Cardiovascular disease is the leading cause of death in women, resulting in approximately 7 million deaths annually, associated with a 2.9-fold greater risk of cardiovascular disease-related death after severe preeclampsia. A large retrospective cohort study by Thalen et al. Showed that women with 2 or more affected pregnancies had increased risk of early all-cause, some specific cause mortality, as well as shorter life expectancy. This association was more significant before or at the age of 50. Recurrent hypertensive disorders of pregnancy is strongly associated with mortality resulting from diabetes, ischemic heart disease, and cerebrovascular events. Thromboembolic events occur with increased incidence in patients who have suffered from hypertensive disorders of pregnancy, like DVT and pulmonary embolism. an increased incidence of type 2 diabetes mellitus, dyslipidemia, and increased BMI noted in patients with a prior history of hypertensive disorders of pregnancy. Though this presentation focused on maternal outcomes, not material outcomes, there have been studies to suggest that there are long-term effects on the offspring of women affected with hypertensive disorders of pregnancy. Some of the effects are cardiovascular disease in later life, an increased BMI in childhood and in adulthood, neurodevelopmental impairment, and offspring suffering from depression in late childhood or early adulthood. This quote by Dr. Gordon Smith is from an editorial based on the study by Thalen et al., and it is an important take-home message for this discussion. A large body of work that clearly demonstrates that women who experience preeclampsia have an increased risk of cardiovascular disease in later life. Moreover, the associations tend to be stronger when the manifestation of preeclampsia is more severe. To sum everything up, hypertensive disorders of pregnancy is associated with an increased lifetime cardiovascular disease risk, and this known association should prompt prevention, early recognition, and management to prevent long-term morbidity and mortality. Thank you and have a blessed weekend.